Pacemaker therapy is a huge market. Alone in the US, approximately 100,000 pacemakers are implanted each year. We estimate that approximately 600,000 people have a pacemaker in the US. But it's not only pacemakers, it's also other devices. For example, ICDs. Approximately 250,000 ICDs are implanted worldwide every year. So, this is certainly something that we have to consider also with respect to endocarditis, because we can find vegetations also on pacemaker leads. And the fact that we're implanting more and more pacemaker leads, especially in elderly patients and in more sick patients, explains why the problem of endocarditis of pacemaker leads is a growing problem. So how often can we expect pacemaker endocarditis? 550 cases per 1 million pacemaker recipients. In other words, 0.5% of pacemaker insertions end up with some form of pacemaker endocarditis. So, a very frequent problem. The increasing incidence is probably caused by several factors. We have more implantations, in particular also ICDs and CRT systems. More leads are being implanted. The patients are sicker and older. And we can make the diagnosis much better now than we could previously. Here are some facts to remember. Again, similar as in prosthetic valve endocarditis, we can differentiate between early and late pacemaker endocarditis. The diagnosis is often made very late because it's difficult to make the diagnosis, as you will see. And the most frequent pathogens, again, are staph infection, either staph epidermidis or staph aureus. And the mortality, as in other forms of endocarditis, is quite high. Almost a quarter of patients with pacemaker endocarditis actually die. Predisposing factors for pacemaker endocarditis are pouch infection, impaired immunity, systemic infection, temporary pacing before the final implantation of a pacemaker, recent manipulation, diabetes, operator experience, and older age. The clinical presentation can be quite variable. Of course, we have signs of infection, but very frequently we don't have high-grade fever but only subfebrile temperatures. And at least in my experience, the typical finding is that as soon as you stop antibiotics, fever reoccurs. Other features or findings include pulmonary embolism and local complications. I've also seen patients who present with septic shocks, and very often, because it is such a chronic form of infection, the general condition of these patients is often poor. But now back to echocardiography, to the diagnosis of endocarditis, and here is such an example, a transesophageal study of a patient who has a pacemaker lead here in the right atrium, and attached to this pacemaker lead, but also to the endocardial surface, is a large vegetation. This is another patient, again a transesophageal study, and again we see a large structure on the pacemaker lead. The echo-dense structure here, which causes an artifact, is the pacemaker wire. In addition, we have a very mobile portion of this vegetation. You do not necessarily have to use transesophageal echocardiography to detect pacemaker endocarditis. Sometimes you can also see it from a transthoracic approach. Here are two examples. Again, we have a pacemaker lead here, and very vaguely we'll be able to see that there is a mobile structure on the pacemaker lead. Here's another example. Again, a pacemaker lead here located in the right atrium, and right here we have a mobile structure, and possibly another mobile structure on this lead as well. So it's quite difficult to detect from both the transthoracic and the transesophageal approach. Both have their advantages and disadvantages. From the transthoracic echo you can see the structures probably better if they're located in the vicinity of the tricuspid valve and further down in the right ventricle. From the transesophageal approach, you see them better when they're located close to the vena cava superior and in the right atrium. In my experience, the typical sites of infection are always where the pacemaker lead comes into some contact with the endocardium. So either in the vena cava superior or close to the vena cava superior as it enters the right atrium, where the pacemaker lead makes a bend, for example, in the right atrium and thereby touches the wall of the right atrium. At the tricuspid valve plane, where it can also cause endocarditis of the tricuspid valve, or sometimes also in the right ventricle, even though vegetations on the right ventricle lead are, at least in my experience, fairly rare or uncommon. Again, an example of such a vegetation, but note that it is also attached to the free right atrial wall right here. As you saw from the previous examples, we can see vegetations both with TE and TTE. TE, however, probably is superior. At least in the literature, we find a sensitivity which is somewhere in the range of 60 to 95% for TE versus 15 to 25% for transthoracic echo. Nevertheless, I still think that if you really try to visualize the pacemaker leads and use atypical views, the sensitivity for the transthoracic approach is probably higher than what has been shown in the literature. So don't forget to use both modalities. And don't forget that both have their advantages and disadvantages. Just to give an example how impressive such vegetations can appear with TE, this is a large vegetation on one of the leads. You can see the leads entering the right atrium here from the superior vena cava, and a large mass on the pacemaker lead. So what are the differential diagnoses? Artifacts, particularly difficult because we have artifacts caused by the pacemaker leads themselves. Thrombi formation, and not infrequently does valvular tissue or subvalvular tissue look very similar as vegetations. To make the diagnosis, you therefore also have to look at other things such as signs of infection, the clinical presentation, and positive blood cultures. Problems and complications of tricuspid valve endocarditis include septic pulmonary embolism. So also look at pulmonary hypertension and pulmonary pressure. Tricuspid valve endocarditis caused by tissue or valvular destruction, which then leads to tricuspid regurgitation, as you can see in this example here. And finally, sepsis. As I already mentioned at the beginning of this chapter, the prognosis of patients with pacemaker endocarditis is not so good. A quarter of patients actually die. And unfortunately, even prolonged antibiotic treatment is often inefficient. So, in most patients, the only way to treat the disease is to pull the leads out and to get rid of the pacemaker system altogether if it's infected. Here are some interesting statistics. 750,000 lead implantations versus 52,000 lead extractions. So you see, a high number of leads are being extracted. How? Well, some of them complete, others partial, and not infrequently do we have to use surgery to explant the pacemaker leads. Keep in mind, the longer the pacemaker lead is within the heart, the more it is anchored to the heart and the more difficult it is actually to extract. Therefore, a number of different methods are now being used to really pull these pacemaker leads out and to not have to use surgery. Here are some examples of techniques which are currently used to extract the leads. Locking stylets, telescoping sheaths and lasers, and even so-called femoral workstations. But better than to have to extract the pacemaker leads, it would be to prevent pacemaker endocarditis in the first place, especially pouch or pocket infection. In our institution, we therefore use routinely antibiotic prophylaxis before we put the pacemaker in. Finally, it must also be mentioned that we can have endocarditis not only on the pacemaker leads, but also on other prosthetic material, for example on indwelling catheters, especially in patients who have septicemia and who have infection. Here's such an example where we have a catheter in the superior vena cava which is coated with the vegetation. This is a clear-cut indication for extraction of such a catheter. So in conclusion, the next time you investigate a patient with a pacemaker implant, don't forget to also look at his leads, especially if there are symptoms which could maybe be indicative of some form of infection.